I guess we can start probably. All right, so it is my honor to give grand rounds today on the topic of iron deficiency anemia in patients with chronic kidney disease. And we'll talk about some of the changes that have occurred in the paradigms we use to diagnose and treat this condition. So the educational objectives are, of course, listed on the handout, but here are the main ones. We'll review iron metabolism and the roles of hepcidin and ferroportin. We'll identify the major reasons for decreased iron availability in CKD. We'll talk about some of the current diagnostic tests that we use and their limitations. And then we'll discuss some of the therapeutic alternatives that we have available. As a disclaimer, I have absolutely no conflict of interest to disclose, being paid what I am. Thank you. So to start off, we'll go back to the basics. Here's the cycle of erythropoiesis, where of course you start from the stem cell, going on to the BFU, the CFU stages, the proerythroblast, reticulocytes, and finally the majorette cells. And under normal basal conditions, namely there's no overt anemia going on, this whole cycle takes about 25 days from the stem cell proliferating and coming out into the peripheral blood as a mature RBC. So we have to know that both erythropoietin and iron are essential for the formation of red blood cells. Now erythropoietin is a hormone made in the kidney, as you all know, and therefore any significant degree of kidney disease will lead to anemia due to decreased production of EPO. Now the precursors of red cells on exposure to the erythropoietin will proliferate and develop into these erythroid precursors. Erythropoietin receptors appear very early on the cells, soon after the BFU stage, and in fact the erythropoietin protects the cells during passage to the bone marrow as they mature. Transferrin receptors appear a little bit later in the cycle, namely on the proerythroblast phase, and once they're inserted into the cell's membrane, the cells can then take up the iron and incorporate it into hemoglobin. And therefore, it is essential that iron be available at that stage. Once the mature erythrocyte is formed, iron can no longer be incorporated into the cell, and the cell will therefore have limited oxygen carrying capacity. Now, once in the circulating blood, RBCs typically have a life of about 120 days. Now we give a lot of erythropoietin to our dialysis patients, as you know, but if for some reason the erythropoietin is held, then erythropoiesis is affected very early in the process. When a few weeks later you restart the erythropoietin, production of the mature cells will be delayed. And so therefore what I'm saying is that there are wide fluctuations in the hemoglobin level whenever we stop and restart the erythropoietin. The current erythropoietin stimulating agents on the market are erythropoietin, the original one, darbepoetin, and then Mircera. There was another agent called peginesetide, which unfortunately had to be withdrawn after some side effects were noted. So let's talk about iron homeostasis a little bit. Despite the fact that iron is the second most abundant element in the crust after aluminum, iron deficiency is actually the commonest cause of anemia worldwide. Biologically, iron is actually more precious than gold. In fact, the mammalian body hoards iron so effectively that there is actually no physiological means of iron excretion. We cannot excrete iron. So the only way to regulate iron stores in the body is by regulating iron absorption. Now, iron is normally absorbed in the duodenum and the upper jejunum. So since we regulate iron absorption, iron excess, of course, can lead to generation of oxygen species, which can cause toxicity. So here's our normal body stores. If you absorb too much, you lead to iron overload, which can lead to tissue fibrosis, organ failure, hemochromatosis, and transfusion siderosis. Iron deficiency, on the other hand, can lead to CNS dysfunction, including impaired cognition and anemia. So here's the iron cycle in a very basic form. We absorb iron from the diet. It's bound to transferrin, can be transported to the bone marrow, which churns out red blood cells, which die in time. They are phagocytosed by the macrophages, and the iron in the red blood cells is then recycled. So the total body iron store averages about 3 to 4 grams, with roughly 2/3 of the iron in the erythropoietic tissue and the circulating red cells, and 1/4 in the reticuloendothelial system. Normal iron exchange is very tightly balanced, very tightly regulated, and it can be maintained at equilibrium by as little as 1 milligram of iron absorbed through the gut and 1 milligram lost, basically through sloughing of the intestinal mucosal cells. Transferrin is the main iron-carrying protein in the blood. It represents a very small portion, namely about 3 milligrams of the total iron body stores, but it is essential as it's the most kinetically active. Transferrin is turned over more than 10 times a day by transporting iron from the iron stores in the gut to the bone marrow. And this, as I said, happens about 10 times a day. Now, transferrin transports iron to several different organs and tissues. It transports iron to the muscle, where iron is needed for a lot of enzymes, as well as for myoglobin. It transports it to the reticuloendothelial system, including the liver, the spleen, and the bone marrow, where the iron can be stored as ferritin, as hemosiderin, and as a labile iron pool. And then finally, transferrin transports iron to the bone marrow, where it is used for erythropoiesis. And about 20 to 30 milligram of iron is utilized that way every day. Now, iron is extremely tightly regulated, so that when your red cells die, the iron is recycled back to the reticuloendothelial system. And as most of the body's iron is contained in red cells, nearly all of the iron needed for erythropoiesis actually comes from dead and dying red cells. Now, how can iron enter the plasma? It can be absorbed through the GI tract, either from dietary iron or through oral iron pills that we may prescribe. Iron recycled from red cells by macrophages. Iron moved from storage sites in the reticuloendothelial system by giving transfusions, and each unit of packed red cells contains roughly 200 to 250 milligrams of elemental iron, and by giving intravenous iron therapeutically. So let's talk for a few minutes about what transport processes are involved. So talking about iron absorption from the small intestine, namely the duodenum and the upper jejunum, and we're going to talk about non-heme iron. So iron 3 is reduced in the alkaline medium of the upper intestine to iron 2, and then can enter into the enterocyte by means of this transporter at the apical membrane of the cell called DMT1, divalent metal transporter. It's on the apical membrane of the intestinal cell. Once inside, the iron is either stored as ferritin inside the cell or can be transported into the blood by means of this transporter called ferroportin, which is on the basolateral aspect of the cell. If it comes out in the blood, the iron 2 is oxidized back to iron 3 and then binds to transferrin, which will transport it in the blood. What about the macrophages? Iron is taken up through phagocytosis, again via the same transporter DMT1, which is also on the membrane of this macrophage. It can be stored as ferritin or can be transported out into the blood by means of ferroportin. Iron can also be transported from storage sites of the liver and the reticuloendothelial cells into the blood, in which case iron is taken up from transferrin via the transferrin receptor on the macrophage. It gets taken into the macrophage, can be stored as ferritin, or can be transported out into the blood through ferroportin. Now finally, intravenous iron. Now that's not really a physiologic mechanism, because after all, these compounds have only been developed about 3 or 4 decades ago. They don't occur naturally in nature. So the proposed uptake is that iron is taken up by macrophages. Once inside the cell, the carbohydrate shell is broken down, the iron can be stored as ferritin or again transported out in the blood by ferroportin and can bind to transferrin. So you can see that the main way by which the body absorbs iron is this exporter called ferroportin. So how is ferroportin itself regulated? Well, it's the only known iron exporter in mammals, and the primary regulator of ferroportin itself is hepcidin. Now, hepcidin is a polypeptide made mainly in the liver, and it interacts with ferroportin to essentially coordinate the usage and storage of iron and iron intake. So here is a little schematic cartoon which will depict it. Again, the main cells that we are concerned with are the intestinal cells and the macrophages. So when hepcidin levels in the blood are high, hepcidin will bind to ferroportin. When this binding occurs, hepcidin causes the internalization and degradation of ferroportin. Now remember that ferroportin is on the basolateral aspect of the cells. Well, the hepcidin causes internalization and then the degradation of ferroportin. Once the ferroportin is degraded, that will reduce the entry of iron into the plasma, right? So focusing on the macrophage first, the binding of the ferroportin to the hepcidin causes the degradation of the ferroportin. Iron can no longer then enter the leave the cell. That leads to accumulation of iron inside that macrophage and low entry of iron into the blood, leading to low transferrin saturation. If you consider the intestinal cell, well, here the ferroportin will be internalized and degraded. That means that iron from the gut cannot be absorbed into the bloodstream, but stays inside the cell. When these intestinal cells die and are sloughed off every 5 to 7 days, that means not only do they die, but when they die, you lose that iron as well, which means that there's reduced entry of iron into the bloodstream, eventually leading to reduced erythropoiesis. On the other hand, when there's low hepcidin around, the intestinal cells can transfer more iron across their epithelial cells, and therefore you have more iron entering the bloodstream. And also iron recycling macrophages can return more of iron into the blood, into the circulation. So the next question is, how is hepcidin itself regulated? So these are the factors which reduce hepcidin. So hypoxia and anemia will reduce hepcidin levels, which means that there will be increased iron entering the plasma. On the other hand, whenever there is iron overload or there is inflammation mediated primarily through interleukin 6, hepcidin levels go up. That means plasma levels of iron will go down. So on the left hand, we have the normal equilibrium. What happens when you have iron overload or hemochromatosis? And we'll actually consider the case of hereditary hemochromatosis, which occurs due to genetic mutations in several genes, TFR2, HFE, HFE2, and the HAM genes. Due to those mutations, little or no hepcidin is made. The low hepcidin level causes increased iron absorption, increased iron transfer into the plasma, so there's extremely high plasma iron levels. So your plasma iron goes up, transferrin saturation goes up, and eventually iron accumulates in vital tissues and vital organs, leading to hemochromatosis. On the other hand, in inflammation, the opposite will happen. Here, hepcidin levels go high. This leads to degradation of ferroportin, and therefore there's reduction in iron entering the blood, reduced transferrin-bound iron, so low erythropoiesis, and we lead to a condition of anemia of chronic disease. Having talked to you a little bit about the molecular mechanisms of all these conditions, let's do a little bit of translational physiology. How does the flow of iron into the plasma translate into the clinical setting? So we'll talk about the diagnosis and treatment of anemia during inflammatory states. So the anemia of chronic disease can be seen in various clinical settings, including chronic inflammation, infections, malignancy, and trauma. And 4 features characterize the anemia of chronic disease. There's, of course, a low hemoglobin, the sequestration of iron inside macrophages, serum iron and transferrin saturation are both decreased, and there's a blunted response to erythropoietin or the newer ESAs. Now, iron deficiency presents differently in an otherwise healthy individual as opposed to a patient with chronic disease. So in a subject who is otherwise healthy but has iron deficiency anemia, typically young pregnant women, there's normal absorption of iron across the GI tract. The iron cycle is not altered by ESA therapy that is administered, and the iron lab parameters are accurate. In chronic disease, on the other hand, rheumatoid arthritis, CKD, for example, or cancers, there's impaired absorption of oral or dietary iron. The iron cycle itself may be altered by the ESA administered, and the iron parameters as measured by your labs may not accurately reflect iron stores. There's also the issue of decreased iron availability in chronic kidney disease, and this happens because of many different factors. Most patients with CKD have diminishing appetite, so their oral intake is low, and therefore their oral iron intake is low. There is impaired absorption across the GI tract due to chronic inflammation. There's also blood loss in the GI tract because many of our CKD patients have AV malformations and telangiectasias. So there's chronic, indolent, slow and steady blood loss. And there's increased iron demand because of the erythropoietin therapy that we administer. And of course, it can be a combination of all these factors. So what are the lab markers that we currently use? There's a whole variety of them, all the way from bone marrow staining, for which of course you need a bone marrow aspirate. Not every patient will agree to get that. And then there are several tests that we use in peripheral blood: ferritin, iron, TIBC, transferrin saturation, transferrin itself, and of course then hemoglobin, and a couple of newer tests that I will talk about. And all of these diagnostic markers measure something or the other in this iron cycle. So iron storage is indirectly measured by serum ferritin. It is directly measured by bone marrow staining, which is the gold standard, but rarely done. Circulating iron is measured by serum iron, TIBC, the total iron binding capacity, and the TSAT, or the transferrin saturation. Now, newly formed red cells in the bone marrow can only take up iron that is bound by transferrin. So therefore, the transferrin saturation is a very important measure. And this itself is calculated by serum iron divided by TIBC. Now, transferrin, the iron-carrying protein in the blood, represents a very small portion of the total body iron, but it's the most kinetically active, and as I said, it's turned over about 10 times a day. And since it is the iron that is immediately available for erythropoiesis, this is the most important iron as far as the bone marrow is concerned. Now, each transferrin molecule has 2 binding sites for iron, and we'll come to that later. Hemoglobin, of course, we all know about. The CHR is the reticulocyte hemoglobin content. You have to read it backward. It's a marker of iron inside newly formed red cells. The serum transferrin receptor is a test based on the fact that iron deficiency will cause erythroblasts in the bone marrow to increase presentation of the transferrin receptor. So whenever there's iron deficiency, the cells make more transferrin receptor, some of which leaches out into the circulating blood, and we can measure it. Now, these 2 tests are actually not very commonly measured in the clinical lab. They're primarily used for research purposes, but they're extremely sensitive and specific. In fact, the CHR has the highest overall sensitivity and specificity and the highest area under the ROC curve. It is getting more and more used in clinical practice, and I think you will see more of it in years to come. Now, how does inflammation affect the tests that we use to measure iron parameters? So we know that in inflammation, hepcidin will be increased. This will restrict iron from leaving the intestinal cells and the storage sites. That will lead to a reduction in transferrin saturation. So to take it up a little further, the transferrin saturation is defined as the serum iron divided by the total iron binding capacity and expressed as a percentage. So TSAT is a calculated measurement and is not a specific value of iron. TIBC is an indirect measurement of the circulating transferrin. It's the total number of available binding sites on the transferrin. And so in iron deficiency, what happens is the plasma iron level is low. However, more transferrin is made. So transferrin concentration goes up, TIBC goes up, iron goes down. So you can see the TSAT will go down. On the other hand, in inflammation, what happens is the circulating iron levels are low because of hepcidin reducing iron transport into the plasma. However, transferrin levels may be decreased because transferrin happens to be a negative acute phase reactant. So if you've got active inflammation going on, transferrin levels will go down. So your iron goes down, transferrin goes down, therefore TIBC goes down. So the TSAT may actually be normal or maybe even a little high. And to explain this, if TIBC levels are very low, lower than 200, you've got less transferrin around. So the TSAT may be spuriously high. So for the same level of iron, because there's less transferrin, here you can have a figure of 27% because transferrin is reduced. However, if TIBC is higher than 200, you've got a normal amount of transferrin going around, and the TSAT will actually be low. So in conditions of inflammation, and with a low TIBC level, your TSAT may be spuriously high and will need to be interpreted with caution. So now what does serum ferritin itself measure? So when iron enters a cell of the reticuloendothelial system, a macrophage, during this process, iron binds to a tissue ferritin, but at the same time, a serum ferritin is released into the blood. The serum ferritin actually contains little, if any, iron at all. So serum ferritin is an indirect measure of iron storage. In patients without chronic illness, serum ferritin is directly proportional to the iron in storage cells. But it is also a positive acute phase reactant. So in patients with inflammation or infection, high ferritin levels may not be completely indicative of iron storage. Now, whenever there's inflammation or infection, especially infection with bacteria, iron, of course, is a necessary cofactor for bacterial growth. So one of the defense mechanisms of the body is that the body tries to take iron away from circulating blood. So it shuttles iron back into the reticuloendothelial system to keep it away from the growing bacteria. So when the iron binds to tissue ferritin, the molecule of serum ferritin is released. So serum ferritin goes high. In liver disease, serum ferritin will remain high because liver is the main organ that clears ferritin. So there's poor clearance of serum ferritin. So ferritin level goes high in liver disease. And of course, ferritin is an acute phase reactant. So in all these cases of inflammation, serum ferritin goes high, but does not necessarily reflect iron storage. And this graph, which depicts ferritin levels on the y-axis in a logarithmic scale, the gray zone is the normal zone. You can see that ferritin is low in iron deficiency. It's mildly elevated in inflammation. It's a little more elevated in liver disease, and it's massively elevated in iron overload. Now, how common is iron deficiency in chronic kidney disease? If you just look at iron indices themselves, namely just iron deficiency, with or without anemia, taking all comers of CKD, in men, it can be about 57 to 58% prevalence. In women, even higher, about 70%. Now, this is defining iron deficiency just by the iron indices, transferrin saturation, serum iron. If you consider iron deficiency with anemia, then of course you're talking about more severe iron deficiency, so the figure will be lower. So across CKD stages 2, 3, 4, and 5, the figure varies anywhere from 15% to 28% if you base it on a low hemoglobin and a low TSAT and a low iron. But if you actually manage to do bone marrow biopsies, the number is much higher. 48% of our CKD patients actually have iron deficiency anemia. So it's a very prevalent problem, and we need to address it in our CKD patient population. So what are the options for treating anemia in patients with chronic inflammation, including CKD? Well, you can resolve the underlying inflammation, treat the patients with erythropoietin stimulating agents, and finally treat with iron. Now, correction of occult infection or inflammation can actually improve anemia and your EPO responsiveness. This is a study from about 15 years ago from Baylor in Houston. They identified 20 patients on hemodialysis who had chronic inflammation, namely a high CRP and EPO resistance. They actually found out that 8 out of those 20 patients had non-functioning old AV grafts. These grafts were resected, and about 2 months after resection, they found out that the patient's hemoglobin went up and the EPO dose required went down, and so did the CRP go down. So occult infection of non-functioning grafts is a pretty common cause of EPO resistance in dialysis patients. It's estimated to be about 21% of these non-functioning grafts can actually have an undiagnosed infection. So now what happens to the iron stores once you start our patients on erythropoietin? Soon after erythropoietin came out in the market, this study was done. They were giving EPO every other day and measured these iron parameters over the course of 7 days. And you can see that in as short a time as 7 days, the transferrin saturation falls drastically, and so does the serum ferritin. So this means that there's a high utilization of iron in patients getting the EPO because they're making new red cells. And therefore, we need to replace iron in patients who are given EPO. So once you start EPO therapy, this causes a superphysiologic increase in red cell formation. This increases the demand for iron in the bone marrow. And we come to a situation where the supply is not equal to demand. The demand far exceeds the supply. And because of that, iron is utilized from the blood very rapidly, leading to a low TSAT. In fact, iron from storage sites may not be mobilized quickly enough to transport to the bone marrow. This results in the TSAT going down. Serum ferritin may actually increase because red cells continue to die and are taken up by your macrophages, but the iron is restricted from leaving those macrophages. Because of all this, eventually your hemoglobin will go down because there's not enough iron available for red cell formation. So in these patients with inflammation like CKD and cancer, you've got low iron availability, low hemoglobin. You give erythropoietin to treat the anemia, which will initially cause an increase in hemoglobin, but will use up the serum iron stores even more quickly, leading to further reduction in iron availability. And this positive feedback cycle is referred to as iron-restricted erythropoiesis. So the continued use of ESAs perpetuates the cycle of iron-restricted erythropoiesis and perpetuates the anemia. So about 10 years ago, this study called the DRIVE study was performed in dialysis patients. These were all patients on hemodialysis, all had hemoglobin less than 11, low transferrin saturation, and they had high ferritins, reflecting chronic inflammation. They were all needing massive doses of EPO, roughly, well, we'll see in the next slide, they were requiring 36,000 units of EPO a week. That's a very, very high dose, signifying EPO resistance. C-reactive protein levels are also pretty high. And they divided these patients into 2 groups, randomly assigned. The control group, they were getting EPO at constant doses, but no IV iron. The test group received EPO and intravenous iron, which happened to be iron gluconate. And this was given for a total of 6 weeks. At the 6-week mark, the investigators were then free to change the EPO dose and the IV iron dose at their own discretion. So this is what happened in the first phase, phase 1. You can see that the yellow is the control group, the blue is the IV iron group. The hemoglobin level went up, and of course the EPO dose was held constant. At the 6-week mark, the investigators were free to change the EPO dose depending on the hemoglobin levels. And you can see that in the second phase, in the control group, the EPO dose didn't change much, but in the iron group, the EPO requirement fell. The hemoglobin continued to increase in the second phase, but the hemoglobin was actually higher in the IV iron group. So patients who received IV iron had an increase of 1.6 grams compared to 1.1 in the control group, and the hemoglobin continued to remain higher in the IV iron group in the second phase as well. So overall, the IV iron group maintained a higher hemoglobin while requiring a lower EPO dose. In terms of the responder rate, as to defining patients who increase the hemoglobin by more than 2 grams per deciliter, 47% in the IV iron group versus 29% in the control group. So this reflects the fact that if you treat these patients with chronic inflammation with intravenous iron, you can actually improve the hemoglobin and reduce the EPO requirements. Now, so far we've been talking about the anemia caused by iron deficiency, but there are also non-hematological benefits of iron. Many of our patients have fatigue, cold intolerance, failure to concentrate, and these are attributed to the anemia. But what's not recognized is that these symptoms can be directly caused by iron deficiency itself. In fact, many animal studies as well as clinical studies have shown that the following benefits occur by treating iron deficiency: improvements in immune function, in physical performance and tolerance, thermoregulation, higher cognitive abilities, restless leg syndrome. In fact, there's a rather large body of literature now which has linked restless leg syndrome to iron deficiency, and if you treat the iron deficiency, the syndrome improves. And finally, to aluminum absorption. So in summary, hepcidin plays a major role in regulating iron homeostasis, especially during inflammation. Inflammation increases the expression of hepcidin. Hepcidin, of course, interacts with ferroportin and causes impaired release of iron, leading to low iron levels in the blood and therefore anemia. In patients with iron-restricted erythropoiesis, there's suboptimal response to erythropoietin. IV iron can be given and can actually improve the anemia. And the currently available lab tests for iron, especially ferritin, may be elevated during inflammation and have to be interpreted with caution. So we now move on to the next part of my talk, which is how do we treat iron deficiency anemia. The IV iron that I referred to a few minutes ago was, of course, gluconate, but there are several options that are available right now. We have iron dextran, both the low molecular form and the high molecular form. We've got ferric gluconate, sold as Felicit. There's iron sucrose, sold as Venofer. Ferumoxytol came out in the market a few years ago, branded as Ferrahim. And the latest entrant is ferric carboxymaltose, sold as Injectafer and Ferinject. There's also another compound called iron isomaltoside, which is not yet available but may soon be on the market. So iron dextran can be given as 1,000 milligrams in one dose. Ferric gluconate is given as 8 doses of 125 milligrams each. Iron sucrose for dialysis patients is given as 100 milligrams times 10 doses, and in non-dialysis dependent CKD can be given as 5 doses of 200 milligrams each, given over about 2 weeks. Ferumoxytol is given as 2 doses of 510 milligrams within 3 to 8 days, and ferric carboxymaltose is given as 2 doses of 750 milligrams each, about 7 days apart. Now, in terms of efficacy, all of these agents are equally effective. They all bring an increase in hemoglobin of the same order of magnitude. So the real practical differences between them actually are the differences in cost and side effects. In terms of cost, you can see that low molecular weight iron, the cost is not that bad. Venofer has a fairly high cost, Felicit somewhat lower, and ferumoxytol has the highest cost. In fact, I don't have it on this slide, but the carboxymaltose has a cost which is even higher than the ferumoxytol, as it's the latest entrant into the branded market. So what are the costs involved in treating patients with iron deficiency anemia? Well, there's the cost of the drug itself, which I referred to in the slide previously. Then there's the cost to the clinic. You are going to use personnel, the nurse, the receptionist, the biller and coder, so there's the personnel cost. There's the cost of equipment because you're going to have needles, cannulas, tubing sets. You're going to dilute the IV iron in some form of fluid, usually normal saline, so that costs some money. And finally, there's the time of the electricity, of the rent, etc. of the clinic. There's the cost to the practice revenue. Most of these IV irons are given over half an hour to 1 hour. So you're going to tie up a room for 30 to 60 minutes, which you have to compare to the revenue you could generate by seeing 2 to 3 patients in that same time. So it's an opportunity cost. And then, last but not least, in fact, most importantly, there's the cost to the patient. There are costs to the patient for traveling to the clinic. And remember that at LSU and at the VA, many of our patients come from a long distance, right? Even from an adjoining state. They travel often for 100 miles. So there's the cost of travel and gas. But more importantly, there's the cost of time to the patient. The patient may not be at a job where he's allowed sick time, which is paid time. All of us are lucky that if we fall sick, we get sick leave, which is paid leave. Many of these people may be on hourly wages or daily wages. And if they don't show up to work, they don't get paid. So this refers to lost wages. So you have to, when you do a cost analysis, you have to include all these costs. Now, the earliest iron agent, IV iron agent, was iron dextran. It came out in the market in the 1970s, branded as Imferon. In the early 90s, it was taken off the market because the manufacturer was afraid of lawsuits from side effects. And after 2 or 3 years, a different company started manufacturing it and marketing it as Infed in the mid-90s. Its popularity as a first-line agent, which was very high in the 70s and 80s, went down over the next couple of decades because of concerns regarding safety, namely the risk of anaphylactic reactions. Also, as time went on, newer agents came out on the market, which was supposedly claimed to be safer. Now, the rate of anaphylactoid reactions that people are afraid of with iron dextran was estimated by a meta-analysis, which found that the rate of severe adverse reactions is approximately 0.6% of patients treated. Now, not anaphylaxis, but severe adverse reactions. And another study found that between 1976 and 1996, a 20-year period, prior to the introduction of low molecular weight iron dextran, probably 31 deaths were directly attributable to iron dextran itself. So its reputation as an unsafe agent may actually be outdated and not fully justified, but continues to overshadow its effectiveness as a therapeutic agent. People are very afraid of it. In fact, Jerry Yee over in Detroit, he noted after a review of several clinical databases that the incidence of anaphylactoid reactions is far less than previously reported. A couple of smaller studies published about a decade ago demonstrated equal efficacy and a comparable adverse effect profile when iron dextran is compared to iron sucrose. Another study in India compared all three, iron dextran, sucrose, and gluconate, and found no difference between efficacy or serious side effects. Glenn Shortau, initially at Stanford and now at UCSF, he showed that while these non-dextrose formulations appear to have slightly lower adverse event rates, however, the overall adverse event rates for every compound are exceptionally low. And here was what he actually summarized. The cost per adverse event prevented is extremely high, namely $5 to $7.8 million per serious adverse event saved. And the cost per life saved from these newer compounds is $33 million per life saved. To put it in context, in the early 90s, when there were trials of TPA versus streptokinase, there was a 1% improvement in mortality by TPA. and the cost per life saved was $100,000. And here the cost per life saved by using a newer agent as compared to iron dextran is $33 million. And in most medical fields, this would not be considered very cost effective. So people are very afraid of using iron dextran. And I found this quote on Up to Date a couple of days ago, which I will highlight here. Many clinicians are reluctant to use IV iron due to an older era when allergic reactions were more common. As also, there's a misunderstanding of the distinction between a rate-related infusion reaction and a true allergic reaction. If you give any IV compound too fast, even an antibiotic, you're going to have an infusion reaction. And the same applies to IV iron. And this misinterpretation of rate-related infusion reactions as allergic reactions can actually convert a minor side effect into a serious side effect. For example, you fairly commonly can see certain side effects like myalgias and chest pain and back discomfort from IV iron. People can mistake that for anaphylaxis. And what do you give with anaphylaxis? You go ahead and give an antihistamine and epinephrine, which will then cause, respectively, hypotension and tachycardia. You will now thereby convert a minor reaction into a more serious event. So the therapy used for a misinterpreted condition actually can cause a serious side effect, and then the product gets labeled as having a serious side effect. So total dose iron dextran infusion means that you give the full 1,000 milligrams as a single dose. It's been used to treat patients with iron deficiency, anemia, and CKD. As I said, the TDI is 1 gram. You give an initial test dose of 25 milligram, diluted in 50 ml of normal saline usually. Give it over about 15 to 20 minutes. The patient is observed for the following 30 to 60 minutes to see for side effects. If there's no reaction observed, you proceed with the total body dose. And then you give the TDI diluted in 250 ml of saline and given over 4 to 6 hours. That's how we do it at the VA. And so far, I mean, I've done several studies which I will present at some later time because we don't have enough time right now. We have not observed any increased incidence of side effects compared with other newer agents. Ferromoxetol came out in the market about 8-9 years ago. It's a semi-synthetic, ultra-small, super paramagnetic iron oxide nanoparticle. It was designed to minimize immunological reactions, and it's actually one of the first nanoparticles to be developed in the history of medicine. This nanoparticle form makes the iron oxide highly bioavailable. The carbohydrate coating, so this is the iron core in nanoparticulate form, which is covered by a carbohydrate shell. This carbohydrate shell is supposed to minimize the immunological reactivity, and it contains minimal free iron compared with other formulations. It's also isotonic and has a neutral pH compared with other molecules. It was initially touted as a very safe agent when it was approved in 2009. Hypertension was reported in about 2% of their initial studies that the FDA oversaw. Serious hypertensive reactions were seen in about 0.2% of patients. However, after it came out in the market, post-marketing data reveals 40 serious events that were noted, and this represents a rate of about 0.1%. So it's really not much safer than the older agents that are on the market. Ferric carboxymaltose was approved about 3-4 years ago. It has an indication for treatment of iron deficiency anemia in adults who either cannot tolerate oral iron or have had an unsatisfactory response to oral iron. It also is indicated for use in CKD patients with iron deficiency anemia. During the initial studies, treatment-related adverse events were actually fewer than with oral iron. Oral iron is not very well tolerated. 26% of patients with oral iron in the control group reported side effects, and only 2.7% with this IV agent. This is a little slide from Up to Date, which compares the different formulations on the market, and you are more than welcome to refer to it. But I think at this point I will stop and open up the floor to any questions that you may have. Well, Suleiman, Dr. Mills, Dr. Levine, any questions? No? Well, thank you very much. And thank you for this opportunity.